Welcome back to the Michael Rothman, a new podcast about health, about mathematical modeling, about saving lives, about using new data streams, about human behavior, and about other things. When we last were together, I was retelling the story of the origin story, like the origin story of Spider-Man or Superman. Well, it's the origin story of the Rothman index. And I had just gotten to the point where we were in the hospital and we were trying to determine if there was a way to quantify how sick somebody was. We came across MEWS, the Modified Early Warning System, and that is a score which takes about a half dozen vital signs, rates each one as to riskiness, totals that number, and gets a total measure of risk, which then is used in a lot of hospitals to possibly activate a rapid response team. So let me take a digression here in the origin story and talk about MEWS and rapid response teams. Rapid response teams were mandated by the Joint Commission, I think maybe in 2008, 2009, something like that, because it seemed like a good idea. If you could identify the early stages of deterioration and get to the bedside, then you had the possibility of averting a crisis and preventing a death, preventing an unplanned transfer to the intensive care unit. That was the idea. But as you recall, MEWS was originally conceived as a way to just identify someone at risk of cardiac arrest. I think it's worth focusing on that for a moment. Cardiac arrest is a very dire circumstance, one in which, if you're not attended to, death occurs within minutes. And so that was the original focus of those researchers. But it was used following that point as a general way of identifying deterioration. And if you think about it, MEWS works the way that it was intended in terms of identifying someone in severe risk of cardiac arrest. What it wasn't designed to do was identify someone in the early stages of deterioration. Almost none of those deteriorations result in cardiac arrest. Yet MEWS was used to activate rapid response teams. And so, as I said, the Joint Commission got on board, but the result is something that, if you think about it, could have really been anticipated. And that is, using MEWS to activate rapid response teams did not result in their hoped-for reduction in hospital mortality. Basically, MEWS fires when there is a crisis. And, the idea is, well, it fires maybe just before someone has cardiac arrest, move them to the ICU. Okay. Well, there are actually problems with that too. And that is, if you are sick enough to have a cardiac arrest and you're moved to the ICU, you have your cardiac arrest in the ICU, you are revived. Unless the doctor can do something to address the underlying condition, the reason for the cardiac arrest, your prognosis remains extremely poor, to the extent that patients who have cardiac arrest in the hospital, about 15% of them survive long enough to go home. So almost 90% of those patients expire in the hospital. One of the things that you can see in the literature is that the use of MEWS has reduced the occurrence of cardiac arrest in a medical unit, in a med-surg unit. And that is because, just as it was intended, those patients, some of them, are transferred to the ICU and they have their cardiac arrest in the ICU. But as I said, the prognosis is so poor that what you don't see with the use of rapid response teams being triggered by MEWS is a reduction in mortality. It didn't stop many hospitals from implementing rapid response teams. But if you look at the literature on rapid response teams, almost all of which are triggered by systems like MEWS, maybe not exactly MEWS, but similar to, highly dependent on vital signs, there's very little evidence that there's reduction in mortality. So what went wrong? Why not? Okay, well, we'll get to the why not, but let's get back to the origin story. But keep in mind that the use of MEWS has not been successful in terms of reducing mortality. Now, of course, there's going to be some article out there that said, okay, in this circumstance, yes, there was a reduction in mortality, but the evidence is very thin that there is actually some impact. But returning to our story, we were in the hospital. We came across MEWS as a quantification of patient acuity, and we took the risk functions developed by those original researchers as a starting point. We added other variables. Now, remember, I didn't have a background in medicine. Neither did my brother. So we're new to this. And it turns out being new to it was not a bad thing. It was a good thing, because then we came across another set of measurements that were recorded in the electronic medical record called nursing assessments. What are nursing assessments? Well, those of you who are nurses out there know what nursing assessments are. Those of you who are physicians or have some other background probably do not. So let me explain. And this was new to me. I didn't know what a nursing assessment was, but when a nurse goes in to see a patient, he or she is not just checking in on the patient, but they're doing a very structured evaluation of that patient, rating each of about a dozen physiological systems as either having met or not met a minimum standard. Let me be a little more specific. So you have your cardiac system, you have your respiratory system, your gastrointestinal system, your general urinary system, your neurological system, and so forth. An example of a minimum standard, let's take gastrointestinal, because I happen to know that minimum standard, and that is if the patient's abdomen is soft and non-tender, if there are 4 quadrants of bowel sounds, that is, you put your stethoscope on the patient's abdomen and you can hear the activity of the bowel. If there's no nausea or vomiting. And if the patient is bowel continent, then you've met your minimum standard for your gastrointestinal assessment. So you would get a rating of MET. If any one of those conditions was not true, if the abdomen was rigid, if it was tender, if there was nausea, and so forth, then you would get a rating of not met. So we were looking at the medical record and we found all these physiological measurements in binary form, met or not met. And I said, all right, well, that sounds reasonable. Let's incorporate those into our constructed score, which we were putting together. And so we did, included nursing assessments, including there was one for pain. And that's a 1 to 10 or 0 to 10 scale. And if you've ever seen a pain chart, they give you pictures of someone's face that you would then use to determine what that number is in terms of pain. Okay, so we came across this thing called nursing assessments, and here is where being a newbie, being a novice, and not having any bias turned out to be important. We later came to understand that physicians may not even know what a nursing assessment is, and almost none of them would look at the recording of nursing assessments as they're documented in the electronic medical record. I would also come to understand that nurses, by and large, didn't believe in the significance of nursing assessments. And the questions posed were, are they accurate? Are they repeatable? Do you get different ratings of a physiological system when you go from one nurse to another? And so here was data being recorded in the medical record at great cost. And I'll take another small digression here because I like to talk about the numbers involved. If you take a medium-sized hospital, 500 beds, the operating budget of a 500-bed hospital is on the order of $1 billion a year. About half of that pays for nursing. You're spending $500 million a year for nurses. Of that 500 million, about half of it is spent in having the nurses enter data into the electronic medical record. So that's about $250 million a year of nurses typing into the medical record. And about 80% of that is in the sort of documentation that I'm talking about. It's called the nursing flow sheet, and the nurses have to answer a whole series of questions about the patient's condition, generally selecting answers from pull-down menus, but also having the opportunity for free text. And so you're spending about $200 million for your nurses to enter the nursing assessments into the EMR. So what happens to that data? In general, nothing. Nurses don't look at it. Doctors don't look at it. I remember speaking to a doctor about nursing assessments, and he thought I was talking about an assessment of a nurse. He didn't know what a nursing assessment was. So we're spending a tremendous amount of money in entering this data, and it's a one-way street. I spoke to a lot of nurses they knew they had to do this documentation, but they also knew that it was really a waste of time. They'd much rather be attending to the patient, checking in on the patient, performing other tasks that they're required to do, but they were required to do this documentation. So here you have a one-way street. And in fact, if you look at the electronic medical record systems that are out there, you find that they are data entry tools for nursing assessments. They don't present the result of the nursing assessments in any particularly easy to understand way. And so they've come to realize that this is a data entry function and not a data display function. Well, so doctors, nurses ignore nursing assessments. We came to believe that nursing assessments were significant. And you'll hear me talk more about that later. But if we were physicians, I'm talking about my brother and myself, if we were physicians, we would have, quote, known that nursing assessment data is irrelevant, just noise. So we didn't know that. So we used it. And guess what? It isn't noise. It's very powerful. And it is one of the keys to capturing what you really want to capture, which are the early stages of deterioration. The nursing assessments can be used to identify the time when there is still an opportunity for the nurse, for the physician to intervene and avert a crisis. That's our sweet spot. That's what you really want to do. Okay. So nursing assessments, we came across these nursing assessments. At the time, we didn't know that they were particularly significant, but we did know that they were available for almost all patients and that they were recorded twice each day at least. So once a shift, and this hospital had 12-hour shifts, so twice a day on all patients. So it was available for all patients, and it was measured frequently, and it was recorded in a nice binary form. Tempting as a modeler to say, these could be inputs to a model. So we built, we were in the hospital for 3 weeks, and I think I might have mentioned this in the last podcast, but we were treated very well by their hospital staff. We were there across both shifts, and we were eating for free using vouchers that they gave us to eat in the cafeteria, which was really quite good. And at the end of it, we developed a simple model using elements of MEWS, using nursing assessments, using another nursing tool called the Braden scale, and constructed a model to quantify patient acuity. And so we come up with a score. The higher the number, the sicker the patient. And okay, so how do you determine if this score means anything? Just because we say use variable 1 and variable 2 doesn't mean that you have something worth doing anything with. And So we did something which I think was important, and I'm not sure that other people really have done this, but the way that we the way that we determined whether there was meaning to our score was we looked at the last score just prior to discharge. Then we looked at the discharge disposition. And we were doing this with data from a cardiac step-down unit, 70 patients. So we had data on 70 patients. And what we found was that the risk from our as quantified by our model for patients that went home was the lowest. For patients that went for rehab, it was slightly higher. For patients that went to a skilled nursing facility, it was slightly higher. There's home, and the second was home with home health. That was the second step. So home with home health, rehab, SNF, hospice, and then death. And we found that the score that we generated increased, the risk that we captured increased as the acuity reflected by the discharge disposition increased. And it was beautiful. It lined up perfectly. And when we presented this to the folks in the hospital C-suite after 3 weeks, after talking to all these doctors and nurses, after having a nurse informaticist, I think her name was Donna Johnson, I have to double check that, help us, they got excited. In fact, someone had told me, someone who had worked on data from the intensive care unit, where there is much more data, said that if we could quantify risk for patients in med-surg units, she would eat her hat. She just didn't think it was possible because there's a dearth of data compared to the data that's available in the ICU. Well, she didn't eat her hat, but she should have eaten her hat. I guess she wasn't even wearing a hat, but you get the point. And so we were off to the races. We had something. And as I said, the C-suite was excited. We were excited. So much so that a few months later, we came back to the hospital with a proposal to do an actual study. And it was well received. I was running a consulting company at the time, so this was in line with my business model. And so we started on a project to see if this simple model, which we had developed over the course of 3 weeks, based on data from 70 patients in a cardiac step-down unit, had legs, whether it was generalizable, whether it was meaningful for patients other than patients in a cardiac step-down unit, whether it could be effective, whether it could do what we hoped, whether it could get us to the sweet spot that we wanted, that is identifying the early stages of acuity, giving nurses and doctors an opportunity to get to the bedside when there was still a chance to affect outcomes. And I've come to my 25 minutes, and this story goes on. It's a sort of a strange tale. It's so unlikely. The fact that my brother went to the CEO of the hospital where my mom died and the fact that he parked his RV in the executive parking lot and they ran a cable to his RV to give him power, and the fact that they let us talk to all these physicians and nurses who were basically, who the heck are you and why are you here? Um, and the fact that we came up with something, it's just strange and fortuitous. And in a way, it was powerful. And they say there's nothing as powerful as an idea whose time has come. Well, this was an idea whose time had come. We were the pioneers in this space, and surprisingly, to a large extent, and for reasons that I'll go into in further podcasts, we still are. Why is that? Interesting question. Okay, well, I don't think I told any funny stories. I wanted to put some humor in this podcast, but I guess I'll have to come up with something for the next episode. Yes, the next episode of the Michael Rothman. And I didn't give my disclaimer. The opinions that I am describing, that the opinions that I am putting forward in this podcast are not necessarily those of Space Labs Healthcare, which is the company for which I work. And I'm grateful to be working for them. So, until next time, this is the Michael Rothman. Hello again to all the other Michael Rothmans out there. I'm sure you are all wonderful and have a great day. And that's it for now.